You got out of bed this morning and something felt slightly off. Not painful, not dramatic. Maybe your appetite wasn't quite there. Maybe your back has been aching in a spot that doesn't match anything you did. Maybe your pants are looser than they were a month ago and you haven't changed a thing about how you eat. You've been telling yourself it's stress, or age, or that bug going around. And for most people, it probably is exactly that. But there is a reason doctors are trained to pay close attention when several small things show up around the same time in someone over 60. Pancreatic cancer is one of the few cancers that rarely announces itself with one clear symptom. It shows up as a handful of quiet, easy-to-explain-away changes that only become obvious in hindsight. Most people have been told to watch for stomach pain and weight loss. That advice isn't wrong, but it leaves out several earlier signals that often show up weeks or months before pain becomes severe. And the gap between catching this early and catching it late is measured in survival rates, not just comfort. Part of the reason this isn't discussed more in a routine appointment is simple. A 12-minute visit isn't built for a conversation about 6 overlapping symptoms and how they connect. So here's that conversation. By the end of this video, you'll understand a connection that even surprises many people. New-onset diabetes appearing suddenly after age 50, with no family history and no weight gain, has been studied by institutions including the Mayo Clinic and Johns Hopkins as a possible early signal of pancreatic changes, not a certainty, but a pattern worth knowing. Before we start, tell me in the comments, how old are you? And has anyone in your family ever been told their symptoms were just aging before a more serious diagnosis came later? I read every comment, and it shapes what I cover in future videos. Let's start with the 6th item on this list, the one that gets the least attention, but sets up everything else you need to understand. Number 6 is unexplained fatigue that doesn't improve with rest. Don't let this position fool you. Nearly every senior experiences some tiredness, which is exactly why this one gets waved away the most often, even though it's one of the most commonly reported early symptoms in pancreatic cancer patients later diagnosed. Most people have been told that feeling tired after 65 is simply part of getting older. That belief is costing some people months of delay, because the fatigue connected to early pancreatic changes has a different pattern than ordinary tiredness. According to information published by the American Cancer Society, fatigue is one of the most frequently reported symptoms among patients later diagnosed with pancreatic cancer, often appearing before any pain does. It's not proof of anything on its own. Plenty of things cause fatigue, but the pattern matters. Think of your body like a business that's quietly losing revenue somewhere in the back office. Nothing on the front counter looks different, but the accounts don't add up, and eventually everyone in the building starts running low on energy because resources are being pulled somewhere they shouldn't be. That's what's happening at a cellular level. A tumor, even a small one, uses energy and can trigger inflammatory signals that leave the whole body running on a deficit, long before anyone notices anything structurally wrong on a scan. For older adults specifically, this connects to something researchers call cancer-related cachexia, a metabolic state where the body's energy demands shift because of tumor activity, distinct from ordinary aging-related tiredness. It's also worth understanding that after 65, many people already have some baseline reduction in stamina, which makes this specific kind of fatigue easy to dismiss as normal. Here's an illustrative scenario clinicians describe often. A woman in her early 70s who had walked 2 miles every morning for over a decade suddenly found herself needing to sit down halfway through her usual route. Her family attributed it to arthritis and the summer heat. Months later, after several other symptoms appeared together, further testing revealed pancreatic changes that had likely been present for some time. This is not a single verified case, it's a composite of the kind of story oncologists describe as common, which is exactly why fatigue alone is easy to miss. What can you actually do with this information tonight? Start a simple daily energy log, just a number from 1 to 10, written down each evening, noting how tired you felt compared to your baseline a month ago. This isn't a diagnostic tool. It's a way to notice a real trend instead of relying on memory, which tends to normalize slow changes. If you notice a steady decline over 2 to 3 weeks that isn't explained by poor sleep, a new medication, or an illness, that's worth mentioning to your doctor, specifically not as "I'm tired," but as "here's my log." Pair this awareness with item 5, which we're about to cover, because both often show up in the same window of time, and when they do, doctors take the combination more seriously than either symptom alone. The next symptom is one that most people assume is just a stomach issue, and that assumption is exactly why it gets missed for so long. Number 5 is loss of appetite and early fullness, feeling satisfied after just a few bites of a meal you'd normally finish. Don't let this one slip past you either. It's often mistaken for a simple digestive slowdown that comes with age. Most seniors have been told that a smaller appetite is a normal part of getting older, since metabolism slows and activity often decreases. That's true in general, but the pattern connected to pancreatic changes tends to be sharper and more sudden than the slow decline of ordinary aging appetite loss. The American Cancer Society lists loss of appetite and unintended weight loss as two of the most common symptoms reported at diagnosis, frequently appearing together. Think of your pancreas like a factory quietly managing your digestive supply chain, producing enzymes that break down fat and protein so your body can actually use the food you eat. When a tumor affects that factory's output, or when it partially blocks nearby ducts, food isn't processed the way it used to be. Your stomach signals full, faster, because digestion itself has slowed down, not because you've eaten enough. This connects to something worth understanding by name: reduced digestive enzyme output. As pancreatic tissue is affected, its capacity to produce the enzymes needed for fat digestion can decline, which is part of why appetite and weight changes often travel together in this condition, and why some patients also notice pale, oily, or unusually foul-smelling stools, a sign of undigested fat passing through the digestive system. Consider this composite scenario, representative of cases described in clinical literature. A retired teacher in his late 60s who had cooked large family dinners every Sunday for years found he could only manage a few bites before feeling uncomfortably full. He assumed it was his blood pressure medication. When the pattern continued for 2 months alongside a 15-pound weight loss he hadn't intended, further evaluation identified the underlying cause. Again, illustrative, not a documented individual case, but representative of a pattern doctors are trained to recognize. What to do tonight? Instead of guessing, weigh yourself once a week, same day, same time, same clothing, and write the number down. A loss of more than 5% of body weight over 6 to 12 months without trying is specifically flagged by the American Cancer Society as a symptom worth discussing with a physician. That's about 8 to 9 pounds for someone who weighs 170. If you notice that pattern, bring the actual numbers to your appointment rather than a general impression. "I've lost weight" is vague, but "I've gone from 170 to 160 in 4 months without changing my diet" gives your doctor something concrete to act on. Pair this with watching for the digestive changes we just mentioned, pale or oily stools, because together they point toward the digestive enzyme piece of this puzzle rather than a general appetite decline. The next symptom is one most people have never heard connected to this condition at all, and it involves your blood sugar. So far, you've learned that fatigue and appetite changes often travel together, and that alone is useful information you could act on tonight by starting that weight and energy log. But the next item is the one that surprises even experienced physicians when they first learn about the research behind it, because it involves a diagnosis most people assume has nothing to do with cancer at all. If nobody has sat you down and explained how these symptoms can connect to each other, instead of being treated as separate, unrelated complaints, consider subscribing, because that connection is exactly what this channel focuses on every week. Like this video, if you've learned something today you hadn't heard connected this way before. And if you know someone over 60 who's mentioned unexplained fatigue or weight change recently, send them this video. Number 4 is new-onset diabetes appearing suddenly after age 50, especially without the usual risk factors like significant weight gain or a strong family history. Most people have been told that type 2 diabetes develops gradually, tied closely to weight and lifestyle. That's true for the majority of cases, but researchers, including teams at the Mayo Clinic and Johns Hopkins, have studied a specific subset of new diabetes diagnoses in older adults that appear abruptly and are sometimes an early marker of pancreatic changes. Research published in journals including Gastroenterology has examined this relationship, finding that a portion of new diabetes diagnoses in people over 50 preceded a pancreatic cancer diagnosis within 1 to 3 years. This doesn't mean new diabetes usually signals cancer. The overwhelming majority of new diabetes cases are simply diabetes, but the pattern is real enough that it's studied specifically as a possible early clue in older adults without typical risk factors. Think of your pancreas like a control room that manages 2 separate systems at once: insulin production, which regulates blood sugar, and enzyme production, which handles digestion. When something affects pancreatic tissue, it can disrupt the insulin side of that control room even before anything shows up on standard imaging, which is part of why blood sugar changes can appear before other, more obvious symptoms. This connects to a concept worth naming directly. Some tumors are believed to release substances that interfere with normal insulin signaling, a distinct mechanism from the insulin resistance that develops gradually with weight gain in typical type 2 diabetes. Understanding that distinction is exactly why researchers flag sudden onset diabetes in a lean, active 68-year-old very differently than in someone with a decade of gradual weight gain and a family history of diabetes. Here's a representative scenario, consistent with patterns described in medical literature. A man in his early 70s, physically active with no family history of diabetes, was found to have elevated blood sugar during a routine physical. His doctor started him on standard medication, attributing it to normal aging. When he developed abdominal discomfort and weight loss several months later, further imaging revealed the underlying cause. This is illustrative of a documented pattern in medical research, not a specific real patient described here. What you can do tonight. If you or someone you love has been recently diagnosed with diabetes after age 50, with no strong family history and no significant weight gain, this alone isn't cause for alarm. But it is worth mentioning explicitly to your doctor as a specific question, is there any reason to consider pancreatic imaging given how suddenly this appeared? That's a different conversation than simply accepting a new prescription and moving on, and it costs nothing to ask. Pair this awareness with the appetite and weight changes from item 5 when new diabetes shows up alongside unexplained weight loss rather than weight gain. That combination specifically is what prompts many physicians to investigate further, since typical type 2 diabetes usually comes with weight gain, not loss. The next symptom is the one most people expect to see on this list, but almost nobody understands why it happens the way it does. Number 3 is abdominal pain that radiates to the back, often described as a dull ache that worsens after eating or when lying flat, and sometimes eases when leaning forward. Most people assume stomach pain from something like this would be sharp and sudden, similar to appendicitis or a gallbladder attack. That assumption causes real delays because pancreatic-related pain is frequently described as a persistent, dull discomfort that builds gradually over weeks, which makes it easy to attribute to back strain, acid reflux, or simply getting older. According to the American Cancer Society, pain in the upper abdomen or back is among the most common symptoms at the time of diagnosis, often present for weeks or months before a diagnosis is made, precisely because the discomfort builds slowly rather than announcing itself. Picture the pancreas sitting deep in the abdomen, tucked behind the stomach, close to a dense network of nerves. Think of it like a house with the electrical panel buried behind a finished wall. When something goes wrong back there, you don't get a clean, obvious signal pointing exactly to the source. Instead, you feel a diffuse ache that seems to come from everywhere and nowhere, because the pain is traveling along shared nerve pathways rather than pointing directly at the organ involved. This connects to referred pain, a well-documented phenomenon where discomfort from an internal organ is felt in a different part of the body because of how nerve pathways overlap. It's the same reason a heart attack can sometimes be felt as jaw or arm pain rather than chest pain. In pancreatic conditions, the pain often radiates toward the back because of the organ's position against the spine and its proximity to major nerve bundles. Here is a representative scenario common in clinical accounts. A woman in her late 60s who enjoyed gardening several times a week began attributing a persistent lower back ache to years of bending over flower beds. Physical therapy provided only partial relief. When the ache began appearing after meals specifically, rather than after activity, that pattern shift prompted her doctor to investigate further, ultimately identifying the underlying cause. As with the other stories in this script, this is illustrative of a documented pattern rather than a specific verified individual. The practical takeaway for tonight: track when the pain happens, not just that it happens. Is it worse after eating, particularly fatty meals? Does it ease when you lean forward and worsen when you lie flat on your back at night? Those specific patterns are more clinically useful than simply describing pain as a 5 out of 10. Write down the timing for a week before your next appointment, because it's worse after dinner and when I lie down, better when I sit forward, gives a doctor something specific to investigate, while my back hurts sometimes does not. This pain pattern connects directly to the digestive enzyme disruption from item 5 pain that worsens specifically after fatty meals, lines up with the same mechanism affecting fat digestion, which is why physicians take that combination seriously when both appear together. We're now at the 2 symptoms most directly tied to advanced disease progression, the ones that, when they appear, most consistently prompt urgent evaluation. Number 2 is jaundice yellowing of the skin and the whites of the eyes, often accompanied by dark urine and pale, clay-colored stools, along with itchy skin. This is different from the earlier items on this list because it's one of the clearest, most specific signals connected to pancreatic conditions, particularly tumors located in the head of the pancreas, which sit close to the bile duct. According to the Mayo Clinic, jaundice is one of the most recognizable symptoms of pancreatic cancer, and often the symptom that finally prompts diagnosis, because unlike fatigue or appetite changes, it's visually obvious and hard to dismiss. Think of the bile duct like a drainage pipe running from your liver to your small intestine, carrying a substance called bilirubin out of your body. When a tumor near the head of the pancreas presses against or blocks that pipe, bilirubin backs up into the bloodstream instead of draining out, which is what turns skin and eyes yellow, darkens urine, and lightens stool color because the pigment that normally colors stool brown isn't reaching the intestine. This mechanism is called obstructive jaundice, distinct from jaundice caused by liver disease, because here the liver itself is functioning normally, the blockage is downstream. That distinction matters because it's part of why doctors specifically look at the pancreas and bile duct when jaundice appears without any history of liver or hepatitis-related disease. A representative account, consistent with cases described in oncology literature, a man in his early 70s noticed his wife commenting that his eyes looked a little yellow in photographs before he noticed any change himself. He initially assumed it was lighting. Within 2 weeks, his skin had visibly yellowed, and his urine had darkened noticeably, prompting immediate evaluation that identified a tumor near the head of the pancreas, obstructing the bile duct. This scenario reflects a documented pattern of how jaundice is often first noticed by someone else before the patient recognizes it in themselves. If you notice yellowing of the skin or eyes, darkening urine, or unusually pale stools, even mild or gradual, this warrants prompt medical attention rather than a wait-and-see approach, because obstructive jaundice can also indicate other treatable conditions, but ruling out the cause quickly matters regardless of which condition is responsible. This is not something to monitor with a log for a few weeks the way fatigue or appetite changes might be. Jaundice specifically should prompt a call to your doctor within days, not a wait for your next scheduled visit. This connects directly back to the digestive symptoms in item 5, since bile plays a role in fat digestion alongside pancreatic enzymes when both systems are disrupted together. The pale, oily stool pattern described earlier becomes even more pronounced. And now, the first item, the one most people don't expect, because it doesn't feel like a digestive symptom at all. Number 1 is the sudden development of a blood clot, most often a deep vein thrombosis in the leg, or in some cases a clot that travels to the lungs. This is not a digestive symptom, and it's not something most people would ever connect to. The pancreas researchers have studied this connection specifically because pancreatic tumors are associated with a higher rate of blood clotting than most other cancers. According to research summarized by institutions including Memorial Sloan Kettering and published in oncology journals, unexplained blood clots are recognized as one of the earlier, less commonly discussed signs, sometimes associated with pancreatic cancer, occurring in a meaningful subset of patients, sometimes before any other symptom appears. Think of your blood like a river that normally flows smoothly, with clotting factors acting like emergency road crews that only activate when there's an actual injury needing repair. Certain cancers, including pancreatic tumors, are understood to release substances into the bloodstream that put those road crews on constant high alert, making clots form even without an injury to justify them. This tendency toward excess clotting is called a hypercoagulable state, and it's specifically associated with several cancer types, pancreatic cancer among them. The reason this matters for older adults specifically is that unexplained leg swelling, warmth, redness, or pain is sometimes dismissed as poor circulation or a normal consequence of aging and reduced mobility, when it may instead be a clotting event worth urgent evaluation regardless of its underlying cause. A representative account, consistent with documented cases, a woman in her late 60s, active and otherwise healthy, developed sudden swelling and warmth in one calf with no history of injury or long travel. She assumed it was a minor strain from yard work. When the swelling didn't improve after several days, evaluation identified a deep vein thrombosis, and further workup prompted by the unusual nature of a clot with no clear cause ultimately identified an underlying pancreatic tumor. This reflects a documented clinical pattern, not a verified specific case being described here. If you notice sudden swelling, warmth, redness, or pain in one leg, especially without an obvious cause like a long flight or an injury, this warrants same-day medical attention because a blood clot itself, regardless of its cause, is a medical emergency requiring urgent treatment. This is not a symptom to log and monitor over weeks. It needs immediate evaluation. Taken together with jaundice, unexplained new diabetes, digestive changes, back pain, and persistent fatigue, an unexplained blood clot rounds out a picture that, when several of these appear close together in someone over 60, is exactly the pattern that prompts more thorough evaluation rather than a wait-and-see approach. What we've covered today isn't about causing alarm over symptoms that, individually, are usually caused by far more common and far less serious conditions. It's about recognizing a pattern early enough that if something more serious is happening, it's caught while treatment options are broader, rather than after the window has narrowed. Pancreatic cancer has historically been diagnosed late more often than many other cancers, largely because its early symptoms are easy to attribute to something else. Understanding the pattern is the tool that changes that. Here's what you can do starting tonight. First, start the weekly weight log we described, same day and time each week, and write the number down rather than trusting your memory of it. Second, begin the daily energy log, a simple 1 to 10 rating each evening for the next month. Third, if you've been diagnosed with diabetes recently and don't have the typical risk factors, write down the date of diagnosis and bring it up specifically at your next appointment as its own topic, not just an aside. Fourth, if you notice any yellowing of your skin or eyes, or unusual leg swelling and warmth, don't wait for a scheduled appointment, call your doctor the same day. Fifth, take a phone photo of your eyes and skin tone in natural light this week. It gives you an honest baseline to compare against if anyone mentions a change later, since gradual color shifts are hard to notice in the mirror day to day. One specific safety note: if you're currently taking a blood thinner such as warfarin or a similar medication, any new swelling, bruising, or clotting symptom should be reported to your doctor immediately, since your existing medication changes both the risk and the treatment approach for a new clot. A question a lot of people are left with after a video like this is what actually happens during the diagnostic process if a doctor does want to investigate further, what tests are involved, and how long the process typically takes from a suspicious symptom to an answer. That's exactly what the next video covers, walking through what imaging, blood work, and specialist referrals actually look like in practice. I'll link it right here. Have you or someone in your family experienced a symptom that was initially dismissed as normal aging before a different explanation was found? Tell me in the comments. Your experience might be exactly what someone else watching this right now needs to hear.